also just understand a little bit better how we can help our patients progress. Because if we're not aware, we're simply not going to be able to treat these issues. So to that end, welcome to this lecture. I have no disclosures. And again, we'll be talking about mental health in athletes, just for those who come on this from being recorded. I was asked if this is going to be recorded, and it is being recorded. So let's see here. So a number of sobering losses over the years across various sports. Some of these faces will be familiar to you, people like Junior Seau, Dave Mirra, some less familiar. Madison Halloran was the person who had just popped up, and then obviously Tyler Hilinski. Sometimes there were stories and documented answers as to what was going on, and in other cases it was somewhat of a mystery why these athletes decided to die by suicide. So I think that these losses have really challenged us to sort of try to understand how can we, one, help our athletes, but also raises a substantial question as to how prevalent are depression and suicidal concerns in our athletic population. Is this a group that's at risk greater than the risk of the population or not? And so to that end, I wanted to talk a little bit about the scope of depression. So in general, 6.7% of the entire US population has had at least one episode of major depression. That number goes up to about 10.5% for people in the college age bracket, and even higher actually in adolescents aged 12 to 17. You can imagine all the changes that people in that last age bracket are going through in their lives, and that is an area that can be particularly concerning for depressive symptoms manifesting. And if you don't ask, or if you're not willing to think about that with your patients, they may simply be unwilling to disclose, because maybe they're not disclosing to their parents, their family, their friends. And so if you can establish a rapport with your patients in these age brackets, because they are at higher risk, I think it's important to do that. Prevalence is substantially higher in females. As you can see, there's about 3 times as high reported depressive symptoms among females in the general population. When we talk about suicide, which will be the other part of our topic today, it's the 10th leading cause of overall death in the United States, and the second leading cause of death amongst the population that typically encompasses our athletic population, those aged 15 to 34. And in this group, it only trails accidents, motor vehicle accidents and other accidents, as a cause of death above all other causes. Suicide rates have gradually increased over the past 15 years, and we really don't understand why that's been the case. But what we do see is that age-adjusted suicide rates, as you can see, trend gradually up across sexes over the course of the years between 1999 and 2014, and it continues to do so. So this is an area we don't fully understand what's going on. Many have had theories as to why this is the case, but no clear answers. And as I mentioned before, I think in our athletic population, the people we often are going to be taking care of at a greater percentage than the typical primary care physician, I think we should understand what is the risk to our athletes, and are athletes at greater risk? I think that is the question. To that end, we're going to get a little bit more into this. So let's talk a little bit about the athletic identity. I think most of you would appreciate that athletes are often seen as pillars of health and wellness. I think we all admit and aspire to being like some of the athletes we enjoy watching on TV or take care of. I certainly feel like it's an honor to take care of many of the athletes at the elite level that I take care of, but honestly, it's an honor to take care of anybody and allow that person to entrust us with their health. So I try not to really treat my athletes that differently than my typical patient. That being said, they're seen as pillars of health and wellness, and in many instances, that perception excludes the possibility of weakness or any sort of emotional vulnerability. Some athletes actually even consider mental health to be a sign of weakness. They just feel like, hey, if I disclose this issue, I'm going to be seen as weaker than my teammates, or I'm going to be seen as less capable on the playing field. Maybe I'll lose my playing time or my position as a starter or on the roster. And so I think this is something that is a myth that needs to be attended to at the very least and potentially dispelled. So the mental health as a stigma is a real issue. And a number of athletes have talked about this over the years. My hope is that the willingness to disclose mental health by active and current athletes will allow others to be more willing to role model off those athletes and be willing to disclose their own concerns. And I actually think that that is the case. And we'll talk about this at the end of our lecture when I open up to discussion about how this may have changed over the course of the careers of some of the attendings amongst us, and what you as fellows are seeing in your own clinics, how willing athletes are to discuss this. So Kevin Love, basketball star, plays for the Cleveland Cavs, has been a vocal advocate for mental health management and advocacy in the sports community and in general. And he said that talking about mental illness and your problems, quote unquote, was a form of weakness that could derail my success in sports or make me seem weird or different. Mardy Fish, high-level tennis player, played in Wimbledon, stated that to show weakness, we're told in so many words, is to deserve shame. And of course, Michael Phelps, the most decorated Olympian of all time and possibly one of the more vocal individuals in sport talking about mental health, states that it was a long, long, long road and I just never wanted to deal with it. And for me, that sent me down a spiral real quick. And he went on to say, Kevin Love went on to say, for 29 years, I thought about mental health as someone else's problem. So life as an athlete. This is interesting. If you ever get into this topic with your athletes in an honest moment, there will be a discussion about the struggle that comes into play with regards to living life in the public sphere, essentially living life in a bubble. I think as many of us who practice on the sidelines, certainly at collegiate and professional events, will appreciate, being in the public eye is certainly not easy. We as physicians having to do healthcare in front of 20 to 70 or 80,000 people at a time can be challenging because you feel like all of those eyes are staring at you. And so you have to kind of put that out of your brain. And most athletes try to do that. But the truth of the matter is life as an athlete is largely public, especially for some of the athletes in US society where sport has become such a big part of life in general. Kate Fagan, who documented the demise, she's a journalist who documented the demise and passing of Maddie O'Halloran, who was one of the more prominent cases of dying by suicide in the recent years. She was a early collegiate athlete at UPenn who basically took her life. She actually jumped off of a parking embankment from elevation and took her life, but had essentially documented her demise over the course of those years through social media. And so social media has become an increasingly interesting venue by which to kind of understand and discuss concerns around mental health. And, the truth of the matter is, Kate noted that transitioning to life as a college athlete, many of you taking care of college athletes, is like walking through an obstacle course wearing a blindfold. Athletes may not recognize maladaptive behaviors and, fear of loss of social, coaching, and financial supports as a college student, saying, hey, I would love to, be on this team, or maybe if I disclosed a mental health or a physical ailment, I may no longer be considered worthy of a scholarship that I worked so hard to get here for. So just think about the pressures in play there. So physicians also, there's the other side of this, there's us. So it's not just the athlete's reticence, but I think there's a real reticence amongst physicians. I think physicians are generally uncomfortable discussing mental health concerns. And there's actually documentation from the research standpoint to reflect that. Team and medical coaching staffs may simply lack the training or experience to identify signs when somebody is struggling from mental health illness. Things like binge drinking, partying hard, taking risks may be maladaptive patterns that could be reinterpreted in other ways as non-maladaptive as part of the culture of that sport, when some athletes may be handling it quote unquote okay, others may really be struggling. So being aware of those adaptive patterns and trying to understand changes in behavior are something to really consider when you're supporting your athletes. So speaking of support, one of the challenges in our athletic population, honestly, is that athletes tend to be actually quite supported, certainly in the the realms that many of us take care of athletes at the collegiate and professional levels, even at the high school level, even at the club select level. Team structures, social connectedness offer a structure for those athletes to embrace in a manner that they can be more connected with their friends. There's more eyes on individuals, so that if something is changing or something is happening to a particular athlete from a mental health or physical standpoint, there's more likely going to be people there to identify that issue. Athletes develop an identity around their sports, and this can be a good or bad thing. Some athletes I've talked to said, I really found that being able to keep to a certain type of structure every day provided me with that identity. It provided me with a group of friends, and it provided me with the support I needed to get through difficult times, times when I may have lost, times where I may have been down and didn't want to talk about it. So keeping that in mind, that establishing your identity through your sport may be a good thing. But if you can imagine that sometimes things go, side railed, that can be an issue. If things go bad with your teammates, if you are now injured and not able to be participating in your sport, suddenly that support evaporates. Many of our athletes, on the other hand, have financial obligations to others, be it pro athletes. They may have scholarship considerations to factor in. They may also, as students, have academic and social obligations. Their coaches may have performance and participation expectations, and they themselves may say, hey, I've been the best athlete in my sport for so many years. That's something that I expect of myself. And it's something that I hope that I can maintain. Injury is a big issue, and I think that one of the areas that really needs to be better understood is the impact of injury on mental health. And of course, there are the team dynamics that we've increasingly heard about, bullying and hazing activities. Where does one cross the line in terms of being in that territory where they're being affected emotionally by the content of social interaction? And then, of course, coaching pressures and parental pressures can be substantially impactful. So I would argue that mental health in this population is not so simple. There are a variety of different factors that come in to play in terms of considering our athletes and how they may be impacted in terms of their mental health. You can see this diagram here, and I'll refer back to this in the future, but you see all the different inputs that kind of come into this play between mental and physical health problems, high cognitive risk traits, different life stressors, things that may be going on in the family, if they may have a genetic predisposition towards depression, anxiety, or other mental health concerns. And then from a physical ailment, imagine getting hurt and dealing with the physical pain of an injury and how that might contribute to their mental illness. And these are all things that are important to kind of factor in when considering somebody's mental health, and being able to be aware will help you address this a little bit better. So expectations. What are athletes' expectations? So 80% of athletes coming to treatment for an injury also wish to discuss psychological issues related to that injury, 80%. More than 40% of athletes who seek out sports psychologists do so with the intent of receiving mental health services. So this is an interesting answer, because maybe 60% are just sent to a sports psychologist. They may not initially be willing to receive the care that they are being deemed as needing. Some are attending it for a hope of performance gain. I need to get over my yips playing baseball, for example, or I need to do some mental visualization. So sports psychologists are used for a variety of different purposes, but at least 40% of our athletes believe that they go to that sports psychologist hoping to manage their mental health better. And truth be told, as I mentioned, many physicians are simply not prepared, informed, or comfortable with discussing mental health with their athletes. I think this is changing, and my hope is that we will continue to change this. A quick shout out, I'm actually the editor-in-chief of a mental health textbook in sports medicine that'll be coming out later this summer or fall, depending on how the situation in the country with the COVID virus impacts things. But it's being published by Springer, and Gene Hong and I are co-editors. So the intent of that book, as well as a few other books that are starting to be prepared or be out there, is to really try to provide content that will help inform physicians to have these discussions with their athletes and other patients as to how to better manage their mental health. So I would argue that sometimes it's simply not so simple as laying this all out in front of you. For example, some of you may have heard of Jonathan Martin. Jonathan Martin, you can see, maybe, hopefully this is projecting, was a football player. He played in the NFL for the Miami Dolphins and then subsequently the San Francisco 49ers, prior to which he was at Stanford. He was involved in a bullying issue on the Miami Dolphins as a rookie, where he was bullied and eventually left the team due to mental stress and anguish caused by these bullying episodes at the hands of another player. And at the time, he had described the following: "You see football as the only thing that you are good at. Your only avenue to make it the shy, depressed, weird kid from high school, quote unquote, cool. Your job leads you to attempt to kill yourself on multiple occasions. Your self-perceived social inadequacy dominates your every waking moment and thought. You're petrified of going to work, playing the sport that you grew up obsessed with." So think a little bit about that. Think a little bit about feeling scared to step into a clinic visit every time you walk into a patient room. Being scared to step onto the sidelines. Many of you as fellows, that first big event that you walked onto the field, I bet you had some jitters there, but imagine feeling dread at the thought of doing that and feeling that over and over again and that feeling not going away. And as some of you know, Jonathan Martin then subsequently lashed out on social media about a year ago during the Harvard Westlake incident, where there was a school shooting at the school, and basically said in this Instagram post that led to ultimately to his involuntary commitment, that when you're a bully victim and a coward, your options are suicide or revenge. And this message came after a period where Jonathan had become an advocate for anti-bullying efforts. He took time away from football and became a speaker on this issue at schools. And yet here a year later was continuing to struggle enough to post this picture threatening others, including, if you notice some of the names on the upper corner, Richie Incognito and Mike Pouncey were two of the individuals who were reportedly involved in bullying him while he was on the Dolphins. And so you can imagine what type of pain and anguish this might represent. So let's talk a little bit about depression in our athletes and what data is available in our athletic population. So clinically significant depression symptoms are seen to be as prevalent in athletes both at the collegiate and professional level as our general population. So when we look at depression symptoms, because often it's hard to diagnose depression formally in a large group of people you're surveying, so you look at depression symptoms instead. And it appears that athletes are as likely to exhibit those depression symptoms as those in the general population. And the prevalence of depression amongst collegiate athletes appears to range between 15 and 20%. So somewhere between 1 in 5 and 1 in 6 of your student athletes who you're taking care of at your colleges as fellows are likely to have depression in that group. And some of you might be aware of that. Some institutions are better at exploring and discussing these matters with their patients, and others are less so. And so I think it's just fair to know that 1 in 5 of those athletes who are walking through your door might be dealing with this, and hopefully they're being more willing to discuss this in these days. You can imagine that failing following a competitive cycle may produce higher rates of mental depression or major depression and mental anguish in athletes post-competition, and female athletes are more likely than males to report those depressive symptoms. A study of 290 women soccer players showed moderate depression symptoms in 16% of those athletes and severe depression in 14% of those athletes. So in 290 professional women's soccer athletes, once again, 1 in 5 to 1 in 6 in that range of those athletes had moderate to severe depressive symptoms. Another study of 400 professional rugby athletes identify higher rates of anxiety and alcohol misuse, as well as a greater risk of depression for those with 3 concussions or more. So here we start to mix in a little bit of a discussion around how concussions and repetitive concussions might impact mental health. And I think that the jury is still very much out there, but I wanted to bring that into this topic because a lot of people have co-attributed depression and depressive risk-taking behaviors and drug use with concussion. And I think it's important to explore that topic a little bit in the context of this. Further, injury and career termination also appear to be independent risk factors for major depressive disorder. So just know that when somebody is injured or they end their career, there is a higher likelihood that they are going to suffer from a depressive episode and a major depressive episode. So keep that in mind. So suicide, switching from depression to suicide. As I mentioned, it's the 10th leading cause of death in the general population. Um, and it is the third leading cause of death among individuals of collegiate age. And as I also mentioned earlier, it's the second leading cause of death among college students, secondary to accidents. In the high school population, this has been studied back in 2005 using the Youth Risk Behavior Survey, which is published by the government every year, looking at risk-taking behaviors amongst our young adolescent and high school age students and people. That study looked at a sample size of greater than 8,000 student athletes amongst a larger population, obviously, of individuals of that age who were not necessarily athletic or playing sports. And athletes in that group did not differ significantly from non-athletes in reporting suicide attempts. So athletes seem to be at similar risk of reporting suicide attempts. In that high school population, female athletes were significantly less likely to consider or plan suicide than non-athletes. So here we're seeing that female athletes, being an athlete, was seemingly protective compared to non-athletes for suicidality. So I think that's important to factor in a little bit. Male and female athletes reported lower suicide rates or lower rates of suicidal ideation and suicidal behavior than non-athletes. So again, there's something about being an athlete that either caused athletes to report less or exhibit less suicidal ideation and behavior. And notably, highly involved athletes, and those were typically defined as individuals participating at the varsity club select levels, were significantly less likely to consider suicide than non-athletes, with a substantial odds risk there. So the more involved you get in sports, it appears at the high school level, the less likely you were to consider, plan, or carry out a suicide attempt. So if we move to the collegiate population, athletes in the college population report a higher self-esteem and social connectedness measure than non-athletes in previous studies. Once again, male athletes seem to be less likely to be suicidal than their non-athletic peers, same as female athletes, but maybe a little less of a difference there. And participation on a team sport at the collegiate level seemed to once again reduce the likelihood of considering, planning, or attempting suicide. So I led a group a few years ago, back in 2014 or 15, we published this data that dated back from 2003 to 2012. So this is a retrospective analysis looking at all NCAA student athletes and looking at that essentially 9-year period of time. And in that 9-year period of time, we were able to identify 35 cases of suicide amongst 477 student athlete deaths over 3.5 million individual seasons. So when you do the math there, it appears that the suicide rate was approximately 0.93, you might as well say 1 in 100,000. And suicide rated, it was responsible for 7.3% of all-cause mortality. So a substantial number of student athletes. So when we looked at the relative risks and broke down that population a little bit more, the relative risk of suicide in males was about almost 4 times as great as that for females. Another point that we identified that I've actually gotten asked about quite a bit by media and others was the relative risk in suicide appeared to be, in football appeared to be 2.2 for suicide compared to other male sports. So if you took a male athlete and a male football athlete, the football athlete is at least twice as likely to complete and die by suicide than male athletes in other sports. And in the college population, and specifically the collegiate athlete population, suicide was the 4th leading cause of death. So that's interesting. It's important to know that. But what about comparing student athletes at the collegiate level to population-based data that we have available, specifically looking at individuals of collegiate age in the general population, and then more specifically collegiate students? When we did that, what we found is that student athletes at the NCAA institutions that we studied, which was all of those NCAA institutions that were reporting these deaths, appear to be substantially less likely than the general collegiate student body, and even more likely so to die by suicide than the general population aged 18 to 22 as reported by the CDC. So interesting that athletes, there's something about being in sports that seems to protect against suicide at those age brackets. So let's take a look at professional sports, because this is a big interest of many. So there's a study of 5,400 retired professional soccer players, and in that group of done in Italy, the reported suicide rates were similar to the general population. Another study of retired soccer athletes conducted in 2015 looked at a 6-year period, and in that group, suicide was the third leading cause of death, followed by accidents, accounting for about 11% of deaths. When we looked at suicide in power athletes, there was an increased suicide rate in male power sport athletes, potentially attributable to things like performance-enhancing drug use. So unclear, there may have been a number of confounders there. And that's the issue with a lot of these studies, is they tend to be retrospective, my own study included, and they tend to have a number of different potential biases in terms of cases reported and a variety of other issues that are at play. So I think we have to sort of take some of this data into consideration, factoring in the limitations of the studies that have been done. The last study there was association between a history of multiple sports concussion with depression and cognitive deficits later in life. So NFL, there was a retired NFL player study. And so there's been a number of different studies that have come out of the NFL that have been somewhat more popular. We'll get to one of those studies in a moment, which is the McKee study. But if you look at population data, there was a study done by Lehman et al. Looking at a cohort of 3,500 retired NFL players credited with having participated in at least 5 seasons. And so in that group, there were 12 deaths from suicide compared to what you would project in the general population as being about 25 deaths. And so once again, we're seeing that maybe despite this largely recently reported issue with athletes taking their lives or dying by suicide, if you look at that compared to the general population, there may not be the differences that we think we're seeing. However, there's a couple issues. As many of you are aware, there seems to be an increasing number of deaths from suicide moving from the 1980s forward. So just keeping that in mind and factoring is something to consider. I just thought this quote that I pulled up yesterday was important in terms of thinking about NFL players who had retired. This was an athlete. Just kind of some of these media reports will bring the power of this story. So, you know, you can look at this issue from a number of different issues. You can look at it from a data standpoint. You can look at it through what somebody's going through in life and still be willing there to support them. So, so bottom line, what was going through my mind was, you know, taking myself out, ending my life. I felt like I was a big disappointment to people. This was somebody who'd played for many years. I felt like I was less than a man because of the things I was doing, and I couldn't really provide for my family like I used to. It was tough feeling like you're 3'0" when you're 6'5". I felt like I didn't have anybody to turn to who could understand the things that I was going through. I was at that point that I just wanted to end it all. So I think it's super important to just be aware that these are the emotions that our athletes are going through. CTE and mental illness, I wanted to go back to that briefly, but that study by Anne McKee that I've brought up briefly, that is pretty much, I'm sure all of you have heard of, which was a focus of histopathologic findings in retired NFL, primarily NFL athletes, identifying findings of and this is clinical pathologic findings of chronic traumatic encephalopathy. So the tauopathy, the degenerative findings, were identified in 99 of 100 NFL athletes in this group of people who had submitted their brains for research. I state that as a convenience sample because it was specifically a group of people who were motivated enough to have their brains donated or have their families donate their brains to this research. That's what I describe as a convenience sample. It's not a random sample. There was in that study, a retrospective review of mental health and cognitive deficits utilizing informants, specifically people who were close to those athletes, to report back on what was going on. And in that population, there was a 57% prevalence of substance abuse in that population. So there was very limited discussion of those topics, substance abuse and depression, separate to chronic traumatic encephalopathy. And one concern I have with these types of studies is that they tend to infer causality. It's essentially inferring causality when there's an association. And so you can't necessarily do that. And hopefully, when you look at this data, you'll look at it with a critical eye and try to understand, hey, where is the data supporting this and where is it not? Because yeah, sure, it's a real concern that we're seeing these changes in NFL athletes. I take care of NFL athletes and I have these discussions. But I don't think it's always fair to attribute all of these concerns to chronic traumatic encephalopathy, especially when a lot of these athletes and others who do not have CTE are struggling with depressive symptoms. So I think it's important to have mental health on its own podium and have its own attention. So as I mentioned, conferring causality in the absence of scientific evidence has impact, and it may magnify concerns related to the safety of college football and other sports that involve contact. And it also disregards the studies I previously talked about. So I don't mean to really get on a diatribe, but I think it's important to just look at the data and say, hey, there are other studies in retired athletes that suggest a lower lifetime risk amongst NFL athletes of mental illness. And it once again fails to embrace the concern that mental illness may be an issue of its own accord, worthy of its own attention. And as Bob Cantu, a very well-known concussion researcher, has noted, suicide is simply, it's a multifactorial situation, and we're not really clear what the factors that contribute to the problem really are. So keep that in mind. So we're making progress. The NCAA has published a number of different textbooks, including the Managing Student Athletes and Mental Health Issues, their Mind, Body, and Sport, and several other publications that have come out, as well as forming at your institutions. Hopefully some of your institutions have multidisciplinary care teams of dietitians, sports psychologists, physicians, athletic trainers, other administrators, or people who may be involved in that patient's care, who come together to discuss athlete mental health issues. We do that at the University of Washington. No other institutions. I remember being at UCLA 15 years ago as a resident, actually rotating through, and they were already doing that back then. So hopefully this is being done at a number of institutions to help you have some support and have the athletes have a structured way of being considered when it comes to their mental health. I think there's a lot of research that is being done, and a lot of research that continues to need to be done. And communication is super important, trying to overcome stigma and have a bidirectional understanding that you're there to help, and they should be willing to disclose if they want to be helped, be it that the athletes in the specific case. I think the goal is to destigmatize, and our athletes have been doing this a little bit more. So DeMar DeRozan, one of our more prominent NBA athletes for the Raptors and now the Spurs, reported that depression's nothing that I'm against or ashamed of when he first started discussing this about a year ago. As I've mentioned, Kevin Love noted, mental health isn't just an athlete thing. No matter what our circumstances, we're all carrying around things that hurt, and they can hurt us if we keep them buried inside. Very well put. Marty Fish, I'm here to show weakness, and I'm not ashamed. And of course, Michael Phelps, since the day that I opened up about depression, it's been so much easier to live and so much easier to enjoy life. And it's something that I'm very thankful for. He said that disclosing and come to grips with this was one of his most important emotional moments in his life, over winning gold medals, and that it's okay to not be okay. So a number of research gaps. Obviously, I mentioned the limitations around retrospective analysis being the primary methodology for the data that's been collected so far. There's a lack of mandatory reporting databases. For some of those of you on this call who are just starting your careers, thinking about prospective research would be a great idea for you to start considering as a way of contributing to your discipline. If you end up in a collegiate team physician role, this is something that is uncomfortable to start initially, but with a few common steps and the help of somebody in your department who may be responsible for helping set up IRBs and research, you may be able to start to collect data, even put out a pilot study during your fellowship, and look at whatever questions are interesting to you, be it mental health or otherwise, but certainly mental health is an area that requires further exploration. There's a variety of data limitations from retrospective data, recall bias, all of those issues. So being able to do the data prospectively is going to allow us to understand prevalence, incidence, and management much better. I think there's a number of opportunities in our communities. Awareness is huge. Having our athletic trainers, our coaches, particularly players, physical therapists, and physicians, all of us be aware of mental health and how its impact on recovery, its impact on well-being is super important. After I'm done with this talk, I'm actually going to be talking about the mental health impacts on one of my distance athletes who has been injured for 6 months now, and she's very, very depressed. And so we're going to spend our time talking about that more so than her injury, because it's actually impacting her recovery. I think the electronic medical record is something that's really valuable to explore as an opportunity to study this a little better. And then, as I mentioned, concussion is something we need to parse out better. The University of Washington actually has a methodology. All providers in the state of Washington, anybody who's certified to provide care to others, be it a physician or an athletic trainer, has to go through this suicide prevention modules in order to maintain and continue their board certification. But that methodology emphasizes this structure that's called the LEARN method, which looks for warning signs and risk factors, making sure to develop empathy and at least exhibit empathy when you're talking with your patients, making sure to ask and assess for depression and suicidal ideation, as well as other mental health concerns. Trying to remove dangers. Guns are a major issue in completing suicide. It's part of the reason why males are more likely to complete suicide than females, is because they tend to use lethal means. So trying to remove lethal means is going to be important, and identifying next steps in your own institution to try to continue to support better triage and health of those athletes. I think it's important that people who are struggling with suicide have these numbers on speed dial. There's the National Suicide Hotline, crisischat.org, and then the text line 741-741, just texting hello is a way of engaging the crisis text line. So having these or giving these numbers to your at-risk populations would be valuable. So as I just wrap this up, take-home steps here, current research suggests that depression seems to be similarly common in athletes and non-athletes across age and competitive levels, and current research does not support that athletes are at greater risk. Does not mean that this is not an issue for us, but it just means that we should be thinking about this in the context of the greater population as well. And athletes are in a unique risk and support environment that we need to factor and understand better. And as I mentioned, more research is needed. And so all of these steps are very important as you move forward in kind of answering your own questions about this. So thank you, guys. I am going to field any questions. I'm going to unmute everybody. So if you hear your own voice or anybody in the background, hopefully I just unmuted everybody. I think I did. So if anybody has questions, thoughts, or comments, feel free to either message me or speak up. Wow. I think that's everything. Everybody's unmuted. So if anybody's speaking, I am not hearing them right now. So I think that, oh, I got a couple questions here. Carly, hi Carly. The PHQ on, so Carly Day is a physician at, she's a head team physician at Purdue University. So Big Ten land, and Carly noted that she's been working on PHQ-4, and all new and returning athletes have been receiving PHQ-4 assessments, and awesome. I'm glad you submitted that abstract. That's pretty awesome.
So I can give you the,
what'd you say?
The Cliffs Notes. I can give you the Cliffs Notes version of the results.
Yeah, that'd be awesome.
So a couple things we found. First of all, the overall incidence of, and again, this is not a diagnosis of anxiety or depression, it's just a screen. So screening positive in the PHQ-4. The overall incidence was only about 6.4%, which is way lower than the probable actual prevalence of it, sorry. And then women were higher than men for anxiety. For depression, they were equal. There was no difference between endurance or non-endurance sports. The highest prevalence was in our cheerleaders, which a lot of that was anxiety. And hold on, there was one more thing we looked at. The most important thing that I thought was super interesting was there was a very large discrepancy between returners and new.
Yeah.
Does anyone want to guess who had the higher prevalence, returning athletes or new athletes?
I would guess new athletes because they're brand new on campus, and at least that's something we've seen, but I'm curious.
Right. So we had a significantly higher prevalence in returning athletes compared to new,
Hmm.
and it was about 7 point something percent versus like 2% or 2 or 3%. We have a couple hypotheses for that we will be testing out this fall, and we will let you know what we come up with. But my general hypothesis is that new athletes are scared to fill it out honestly because it's part of their regular PPE, and they're scared they're going to get disqualified. Whereas returning athletes get bombarded with us normalizing mental health all the time. And a lot of them have probably even seen our sports psychologists, and I think they feel more open about filling it out honestly. And so if my hypothesis proves true, which I'll let you know next year, then I'm probably going to recommend that the PHQ-4 or whatever mental health screening you do is after clearance has occurred. So you do a regular PPE. Again, it's hard because this adds work for everybody, but you do a regular PPE, you clear them, and then sometime later you do a mental health screening so they don't feel like it's the first time they're meeting the doctor and it might affect their clearance.
That's totally, that's actually what I've started doing with my athletes as well in the past couple of years, is I found that a lot of people answered it, one, because they're worried about clearance, and two, a lot of athletes have noted that, at least the new ones have mentioned that they were worried about, they just were having a tough time adjusting to showing up at college. We didn't see the same differences you did between our returners and new athletes, but that's actually really interesting, and I'd be curious to see how that how that plays out. So thanks, Carly. Anybody else? I think.
I
Oh yeah.
Oh yeah, we had. I'll turn my video on if anyone wants to see me. We had this issue, not issue, but we had this discussion related to our athletes here in Maine, and they all do, I think, the PHQ-9 as part of their like paperwork before they start. And when we're doing their PPEs, we usually will look at it and see the paper as a screener. But the discussion we had was the importance of, regardless of what, obviously if you see something that sticks out on their questionnaire, you address it, but still having the discussion with them in general, just saying, do you have feelings of depression, anxiety, whatever, helplessness, hopelessness, and that in and of itself, on more of a personal level, when you have them in your exam room,